Acute rhinitis, acute sinusitis. Chronic rhinitis can be allergic or non-allergic. What's the difference? When do you develop atopy? Age, yeah, 2 to 3 years, absolutely. You have to spend a little while inhaling allergens. And if you've got the right genes, you become atopic, which means you've got positive skin prick tests. What's the prevalence of atopy in our society? Amongst our kids. If you skin prick test 100 kids in New Zealand, what do you reckon the prevalence will be now? 50%, yeah, toss a coin. Half our kids are atopic. Now, not all of them have allergic diseases. Not all of them have got asthma or hay fever or food allergies, but about half of them are atopic. Pretty fascinating, isn't it? Jonathan Bostock would have a field day. He'd love it here. So, that's when the kids develop it. That's when allergic rhinitis and allergic asthma starts. But then there's a whole other group of patients who you've all got in your practice, because these guys are as common as muck. And that's non-allergic rhinitis. Histopathologically identical to allergic rhinitis, but pathogenically different. It happens in late adolescence, early adulthood. People truck along, they're perfectly well, and then they start getting rhinitis and sinusitis, and after that, that's adult onset asthma. And so and it's usually an eosinophilic infiltration. What it is that is driving that is entirely unknown, but it is non-allergic. And you can sort that out with skin prick testing. Pathogenesis of allergic rhinitis, you make specific IgE for reasons which are best known to no one. Why should you make specific IgE to a grass pollen protein? You know, with dust mites, that specific IgE, it's directed against a serine protease they secrete in their gut, which breaks down the keratin that they eat. That's why they're in our bedclothes and stuff. They're eating our skin flakes. And they break it down, and they poo out their little dust mite pellets, which have got this protease in it. And that's what the specific IgE is directed. You know, it makes no sense. Nobody understands that. But anyhow, if you are genetically predisposed, so if both your mum and dad are atopic, the chance of you being atopic is about 50%. Good Lord. It's probably more than that. But it's much, much, much higher than if they're not. And you know about the cross-linking and such like, and the release of histamine and leukotrienes. Grass pollen, dust mites, seasonal versus perennial, and of course cats, perennial allergens, molds, perennial allergens, all pretty straightforward. Can be sorted out with skin prick testing. Cheaper and easier generally than RAS testing, which is when you detect the specific IgE in the serum. And that's what it looks like. You just measure the wheel size. It's real easy. Okay, so that's just a little aside on chronic rhinitis. What I really wanted to do was focus on chronic sinusitis. Here it is without nasal polyps. That's the mucousy form which doesn't have the polyps. And what fundamentally it is about is disruption of the normal mucosa, which you've got that nice cilia and mucociliary blanket, and you clear it all and you have normal mucus. And what these guys, and this is one of our fellows, this is Raven Campbell, who I'm sure you remember, she went down to the School of Biomedical Engineering and did these scanning electron microscopy shots of beautiful normal mucosa, poxy, sinusitis. See the cilia are all rogered. See little bugs? Possibly fungal hyphae. It's hard to know, this is the thing, everything's just sort of grey with SEM. Nonetheless, it's, you know, you can see it's sort of devastated. What I suspect, I'll go into this, I've actually got some diagrams. I will not be more circumlocuitous than I usually am. How does all of this happen? Injury to the mucociliary mechanism. Most of your patients with chronic rhinosinusitis were normal. They were healthy until age 25 or 35 or 45, they develop it. And I think that this is what happens. There is injury to the mucociliary mechanism, which is probably viral. We clear the virus because it's a cold, and we recover because that's what most of us do most of the time. What happens with some people is, and whether it's the cold is really bad, the virus is nasty, or our immune response to it is nasty, or there's some sort of secondary change, who knows? The biofilm may change. We don't know what it is, but in a small percentage of the sequelae of acute viral rhinitis is chronic rhinosinusitis and a chronic inflammatory response. What we do know is that kids who have got RSV, if you follow them up for 10 years, after a single episode of RSV, the possibility of their developing asthma is significantly increased. So viral infections have got the ability to alter our state of mucosal reactivity. So for years we have been swabbing noses and trying to grow stuff from them, which you can do, because everyone's nose is filthy dirty, because everyone's mucosal surface is covered with a biofilm. And what grows, and some bugs are really good at growing in petri dishes, and this is why your colleague who only treats what he can grow, what he can see, my goodness me, there's a whole lot of stuff you can't grow, and it causes problems. And this is a real difficulty. As soon as you start antibiotics, what do we culture? And what do? If we swab all of your noses, 30 to 50% of you will have staph in your nose. So do we give you all Fluclox or doxycycline or whatever? No. What happens if you do soak somebody with chronic rhinosinusitis with antibiotics? Often they feel a little bit better for a short period of time. Does it cure the illness? No, it doesn't. So these are all sort of things to have in the back of your mind when you launch into treating this. Bugs in the nose, and this is true for all mucosal surfaces. Bugs in the nose exist in a planktonic form in the mucus. They exist in biofilms where they've got a little bit of a matrix in between them. They're sort of stuck on the surface and are much harder to clear. And most of the bugs in our body are in biofilms. And an interesting thought about how many bugs there are in our body. Because for every human cell, there are 10 bacterial cells. But it gets better than that, because for every human gene, there are 100 bacterial genes. So most of the complexity of genetic material in you is not you. It's your bugs. And are they doing something to you? Yes. Lots. So we have a mucosal commensal community. If you're a pathogen and you want to set up, you've got to fight your way through the jungle. And you may or may not be able to do that, or the mucosal commensal community, they're there, they're good at living in your nose, and they may well repel invaders. They cause a sort of tonic change to the inflammatory response in the mucosa. And I can remember a picture in my pathology textbook when I was a medical student of the ileum from a germ-free mouse compared to the ileum of a wild-type mouse. I don't know if any of you all seem younger, except for you. But the germ-free mouse had a tiny little ileum with hardly any inflammatory cells in the lamina propria. There's this tonic thing going on with us and all the bugs around us. So they have a pronounced effect. There are intraepithelial bacteria, and we've made some of the first, is about 10 years ago, one of my research fellows made one of the first observations of these, and a few groups have subsequently confirmed these findings, that at least half of the patients with chronic rhinosinusitis got bugs in the epithelium, and that's an example of one of his slides, Staph aureus, or below the epithelium. These bugs are really good at growing with us, and they're really hard to kill. And that's his finest example, intramucosal colony. No inflammatory response around. It's not an abscess. These guys are subverting our local immune response. So it's real fascinating. This is my team up in Auckland. It was my team up in Auckland about a year ago. It's changed slightly. But all of these guys are doing degrees in various forms of the immunology and microbiology of nasal disease, which is endless. Well, I think endless. Okay. It is endlessly fascinating. Yeah, well, I think so, for generations. Yeah. Yeah, it's awesome. And you can biopsy it. Because all of what's going on, and we read the respiratory literature and gastroenterology literature because there are so many similarities, role of antibiotics, role of probiotics, and blah, blah, blah. But these guys can't just put an endoscope up and take a little bit of mucosa out of the nose. Anyhow, this talk, which we'll eventually finish, seems to have been going all morning. Look, I'm going to run over medical management very quickly because the evidence for it is appalling. You've only got 4 choices, which makes it easier. Prednisone, I've already talked about. Intranasal steroids, wonderful drugs because they're safe but only partly effective. Saline irrigation makes a few people happy because it washes the snot out of their nose. Can you get sinus rinse into a healthy sinus? Hardly at all. Can you get sinus rinse into a diseased sinus? Not in the month of Sundays. And antibiotics. Now, we keep talking about this, and I'm going to give you a super quick thing about what I think about antibiotics. Intranasal steroids, I love them. Mometazone, I've already mentioned today. I think mometazone might be, we should have it here. It would be good. Everyone who has mometazone in their society loves it to bits. It is their topical steroid of choice. Now, I'm going to resist a slight diversion about fluticasone, but I won't. I've just been told, and I haven't actually read the paper myself, but I've been told about this in COPD using fluticasone. If you use fluticasone in non-eosinophilic asthma or reversible airways disease, you tend to have more infections than if you use a non-lipophilic topical steroid. Jeff Garrett's just sent me an email about that.
So what's the non-lipophilic ones?
Mometazone.
Mometazone.
Mometazone and potentially budesonide. The problem with budesonide is the bioavailability of budesonide is higher. So it's just a thought. If it's eosinophilic, that's not an issue. I think most of the stuff we're treating in the nose is eosinophilic. But it's just a thought with people with recurrent, true, sort of real snotty mucopurulent infections, whether changing to, in our situation, budesonide might be a smart move. But anyhow, that's the sort of dose that you need for sinusitis. What's the systemic effect of taking that? 0. What's the local effect? A few people will get bloody mucus. You can usually fix that by reducing the dose and sometimes by getting them to put a little bit of Vaseline in their nose before they squirt it in. Now, that's what another one of our research, or my research fellows did. That's a CD reconstruction of the sinuses that have been operated on. You can see the frontal sinus, and that's the nasopharynx, and that's a computerized fluid dynamic model of where all the stuff goes, because actually getting topical steroids where they need to be that's really the issue. Flixenase works, or Butacort works for allergic rhinitis, because when you squirt it in, it lands on the head of the inferior turbinate, where probably 70 or 80% of your symptoms come from with allergic rhinitis, the head of the inferior turbinate. But that's really not where the money is with sinusitis. And again, just as sinus rinse can't get into the sinuses, topical steroids have a problem. And that's really the idea about using prednisone, as it were, almost to open sinuses up. And at the same time, you start topical steroids so that what you hope is whatever benefit you might derive from systemic steroids may continue or be maintained with, sustained with the topical steroid sprays. Sinus rinse, dead easy. You can mix it up with those extraordinarily expensive sachets, or you can do half and half mix of salt and baking soda for nothing. And I have a lot of my patients on xylitol, which is a 5-carbon sugar. You can't absorb it. Bugs don't like it very much. And you just need a solute. That's all it is. It's a solute. And that's it's $30 a kilo. That was our first rhinology fellow. Antibiotics. I haven't got to yet. Mm-hmm. What to do? These are data from North America, published just a few years ago. What's in the US, this is adults getting a script. The commonest single indication for adults is rhinosinusitis, and which was, I think it's 11% that adds up to. 7% were for chronic rhinosinusitis. So it's our, you know, that's I don't know, that's hundreds of tons of antibiotics, I would guess, to get onto this graph. So the question is, does it cure anyone? No. What are you doing to resistance? And what's the effect on all of these commensals, which outnumber you 10 to 1? Should you be their friend? Probably. Long-term antibiotic treatment. CRS at S's are without nasal polyps. There are 2 trials, so I'm very quickly summarising the evidence. There are 2 trials, both with macrolides. They had some positive effects, which were short-term and only occurred, surprisingly, in the patients with low total serum IgE. They think if the macrolides work, they may be working as much by their anti-inflammatory activity, because they reduce cytokine production as much as their antibiotic activity. That's it. That's the evidence for efficacy of antibiotics in chronic rhinosinusitis. Now, do I give it as part of maximal or appropriate medical therapy? If a patient were drug naive, yes, it's entirely reasonable. The reality is that by the time I get to see them, you guys have all managed them medically. And I get to see the ones who are resistant to medical management. And so if you've given prednisone, you've given course of antibiotics, you've given topical steroids, and you've given saline, what the devil else are you going to do? Not much. And what I don't think is giving a month of augmentin, a month of doxycycline, a month of roxithromycin for truly chronic rhinosinusitis is necessarily the way forward for them. Definitely give them prednisone. It's very reasonable to give them a course of slightly longer than usual antibiotics. I think it's reasonable to do that once and to see if it makes a significant impact, because it does on a few patients. But if it doesn't, you've got to think of another way to fix them, I think. We've actually done antibiotics to death, almost. And can we do surgery now, because it's much more exciting? Anyhow, so you fail medical therapy, so then you need to consider other possibilities. And the other possibility, if patients want to have it fixed, is to think about surgery. And the idea with surgery is to relieve the obstruction, because it's thought that the obstruction changes in some way the microenvironment in the sinus. And so what you want to do is get sinuses that look like that with great big holes. And I think I'm going to have to sit here like this. There we go. Great big holes. Yes, perfect. I will not move. And then they're good. Sometimes I've got quite subtle things. This is a posterior accessory ostium causing mucus recirculation, just 2 holes in the maxillary sinus rather than 1. And they get postnasal drip, and you just do a real simple little thing. You can see the 2 holes, one's hiding in the corner at 3 o'clock, and you just join those 2 up, which is dead easy. You can actually do this in clinic with some local, and it fixes it. Whereas some people need, these sort of guys need more extensive surgery. So it's horses for courses for a bit. This is a mega enterosin, making a huge hole in the maxillary sinus and getting out this sort of stuff. And this is, when you see the sort of stuff we see in sinuses, you think, oh, that's why I couldn't get better with pills and potions. There's some of the stuff in us, the patient's sinus, and my goodness me, it's awful. And sticky. And this is why it doesn't always wash out. Anyhow. And gooey. When it smells, what do you think of? Yeah, where do the anaerobes come from? Do you get a whole lot of... does the sort of snot in your nose smell as a rule? No. And if patients say, oh, it's smelly, think of their teeth. Because that's the clue to odontogenic sinusitis. And what happens is that the mouth anaerobes crawl up through rotten teeth. They get little periapical abscesses in the maxillary molars, and it pops through into the maxilla. And that's not an uncommon cause in our society, where dental hygiene is not stunning. And we had a patient in DCC who had a subdural abscess and huge brain swelling because of that. It was his tooth. It was all coming up. You could sort of almost see it. And anyhow, you want to make the holes big, and that's a frontal sinus being made bigger, but you're sort of limited by your anatomy. If it doesn't work, then you can make it bigger still. You can actually drill out the whole sort of floor of the frontal sinus and give them a whopping great hole. So there's lots of stuff you can do to make, and all we are really is sinus plumbers. And if you plumb the sinuses, all the goo comes out, and you can get the good stuff in, as it were. And that's all I have to say.